Great. Thank you, Oscar. Those were some wonderful cases. Now that everyone's expert on evaluation of the fetal heart, the gastrointestinal system, the genitourinary system, we're going to move on to skeletal dysplasias. Something that we don't usually hear a lot about because these are entities that are fairly rare. So we don't see that many very often, maybe a couple times a year for most people at most. But I'm hopefully going to try to break it down so that this doesn't become overbearing when we see a fetus that we're concerned about. And I'd like to try to make it easier to institute that type of evaluation. And I hopefully will convince you that we will be able to diagnose the vast majority of these in utero. At least that's my goal. So we want to understand the breadth of the sonographic findings in various skeletal dysplasias. And again, as with the fetal heart, developing a standardized approach is going to be very important to evaluate the fetal skeletal system. And lastly, again, I really think, and I'll show you, that we should be able to evaluate the vast majority of these antenatally. So the current term in English that's acceptable to use for those with skeletal dysplasias is dwarfs or little people. And these are made up of hundreds of distinct medical conditions. The nosology of genetic skeletal disorders lists over 450 different conditions that are associated with skeletal dysplasias. And these are grouped in various ways, both clinically, by molecular biology now, biochemical, and or radiographic criteria. The overall prevalence is fairly low, 2 to 5 per 10,000 births. So even in a busy obstetrical ultrasound practice, we're not going to see these very often at all. But it depends on how the cases are included. If you only look at lethal cases, that number is close to 1 in 10,000. Which is a fairly low number. It can be as high as approximately 1 in 1,000 if you include those at high risk, especially with consanguinity. A number of them have the known mutation, and this is evolving at a very fast rate now. The more we understand the genome, the faster we're understanding how these mutations are identified, and that's allowing us to identify them prenatally at a much faster rate. So as I mentioned, these osteochondrodysplasias represent a very heterogeneous group of disorders. Prenatal diagnosis is uniquely able to evaluate these fairly readily because of the echogenicity of bone. So we're able to evaluate these during pregnancy quite readily. It's optimal to make the diagnosis prenatally, although a lot of times we're not able to. In fact, even postnatally, it can be very difficult for some to make these diagnoses. The key point, however, is to make sure that we determine the lethality. And we're able to do that fairly readily. In fact, the lethality has been accurately predicted in over 96% of cases. So that's very important because that's very important information for women when we're scanning these cases. The International Skeletal Dysplasia Registry that was developed probably about 20 years ago now, and it was a retrospective analysis of over 1,500 cases of skeletal dysplasias. Approximately 15% of them were different types of genetic syndromes and early intrauterine growth restriction, but 85% were well-defined skeletal dysplasias, and the most common were osteogenesis imperfecta type 2, thanatophoric dysplasia, and achondrogenesis type 2. They looked prospectively then and were able to confirm these frequencies. So you can see in this graph from 2008 that achondrogenesis, osteogenesis imperfecta, and thanatophoric dysplasia make up the majority of those single diagnoses. But there's a lot that are based on different syndromes, those that remain unclassified. So I think this is important because we cannot always make the diagnosis antenatally, and it's important to know that. But I'm going to convince you, I hope, that we can make the diagnosis in the vast majority. When you look at the ultrasound evaluation, sometimes family history is important for many things we do in obstetrical ultrasound, although for skeletal dysplasias, most cases are isolated, so we don't see a lot of benefit from knowing the family history. The only time that's not true is with consanguinity, because those cases show a higher risk for skeletal dysplasias. We do know that long bone biometry, measuring the long bones, especially the femur and the humerus, is very helpful for assessing gestational age, looking at estimated fetal weight, and looking at the risk for Down syndrome. So how do we begin to consider the diagnosis of a fetal skeletal dysplasia? Some people have proposed various thresholds, such as less than the 5th percentile or the 1st percentile, or less than 2 standard deviations of long bone length, to consider the possibility of a skeletal dysplasia. We'll get to that more in a minute. One thing I also want to mention is that sometimes we can't diagnose skeletal dysplasias until later in pregnancy, but most of the lethal skeletal dysplasias are identifiable in the 2nd trimester. So as part of the ultrasound evaluation, I think what is very prudent is if we see a femur length and a humeral length, those are lengths of bones that we do tend to measure routinely in all fetuses. If we see any that are less than 2 standard deviations, that's not diagnostic of a skeletal dysplasia, but I think that that's very helpful for us to consider serial growth scans, such as every 3 to 4 weeks. Scanning less than 3 weeks is not usually that helpful because there are variations in our biometry at less than 3 weeks. So the error rate is much greater. So I would urge every 3 to 4 weeks if we're concerned about the growth. Then if the femur or humerus is less than the 1st percentile, for sure, I would, or if the serial growth scans show decreasing fetal growth of the long bones, then I would then evaluate all the long bones that should be measured and evaluated. Again, I'll mention that some skeletal dysplasias, such as heterozygous achondroplasia, may not be apparent into the 3rd trimester. So I actually just had a case about 6 weeks ago of heterozygous achondroplasia. She had a completely normal 18-week scan and then came in at 31 weeks, and the bones were seriously shortened, and it did turn out to be heterozygous achondroplasia. So just to show an example of one case here, we have a 34-year-old G2P1001 with a family history of a skeletal dysplasia, presenting at 16 weeks gestation. And so because of that family history, we measured all the long bones and did serial growth scans. So here is the biparietal diameter of 34 millimeters, which is right around 16 weeks. And then we measured all the long bones. We have both humeri, we have the radius, the ulna, the femur, the tibia, and the fibula, and that is really important to make sure, and I'll explain more why that is in a moment, but evaluating all the different bones will be helpful when we're trying to hone in on what the diagnosis is. It is also important to look at the hands and feet. Usually, unless there's a club foot, the foot size, if you measure it from heel to toe, is pretty consistent with the femur length, or at least it should be unless there's a skeletal dysplasia. So that information is very helpful. And we'll go into evaluation of the fetal hands more in just a moment. So once we have that data, we can plot it all out. And we see that even though she has a history of a skeletal dysplasia, we see the biparietal diameter and all the long bones are fairly well conserved within the normal range. So there's no concern for this case, and that can be very reassuring to some women. Well, if we're going to evaluate for skeletal dysplasias, we have to understand the different types of entities and growth abnormalities that can be present. So various skeletal dysplasias can affect different parts of the fetal skeleton. We have a normal upper arm, and this is just an example, very simple, radius, ulna, and hand. If you have rhizomelic shortening, that's going to be primarily the upper part or the upper arm bone, the humerus. If we have mesomelic shortening, that's going to be the forearm preferentially. If we have acromelic shortening, it would mean that the upper arm, the forearm, would be normal or close to normal, and then would have the digits being small. Micromelia is typically reserved for the entire extremity being shortened. So these are important as we try to hone in on what the diagnosis is. Being able to look at what bones are short will be very helpful for us. So not just measuring the bones, but looking at their consistency is also going to be important. We have a normal example here. Bowing of the extremities of various bones is going to be important for us to look for. Fractures in the bones, because that can be associated with, for example, osteogenesis imperfecta and others. Demineralization, so we see this is a little bit lighter or less echogenic, and that's going to be important, and I'll show some examples as we come up. Or absent bones, such as the radius being absent here, and we have ulnar deviation. Looking at the hands, as I mentioned, you can have hand abnormalities. Here's normal. Syndactyly of a couple digits. You can have different types of polydactyly, and some are more preferentially associated with different skeletal dysplasias. If you have preaxial polydactyly on the thumb side, an extra digit, or postaxial polydactyly on the pinky side, the small finger, that is associated with other types of skeletal dysplasias, although they can, they're not always very specific. They sometimes can be. Or a trident hand, and I'll show examples of that where you have kind of the hand separated into three kind of segments. When we're doing our evaluation of the extremities, when we look at the spine, we want to look at the mineralization of the spine, how echogenic the bone is, platyspondyle or thinning of the vertebral bodies, the curvature of the spine, and the presence of any hemivertebra. The cranium, again, mineralization is important, whether there's frontal bossing, any abnormality of the sutures prematurely fusing, such as with craniosynostosis, and a cloverleaf skull, which is somewhat related to that. We also want to look at the face. Facial clefts are important. Any hypertelorism or hypotelorism, mid-face hypoplasia are all important factors to evaluate. And the thorax, as we mentioned, the importance of determining lethality, that's going to be most important by looking at the size of the thorax, whether there are any hypoplastic ribs. The ribs should cover 70 to 80% of the chest wall. So we'll show examples where that is not the case. Rib fractures, a bell-shaped chest, and pulmonary hypoplasia. I really would like to delve into the diagnosis of lethality. I think it's very important, but there's so much literature and so much to evaluate. That'd be a whole talk in and of itself. When we extend our sonographic evaluation, we want to look at the presence of clavicles. That can be important for some skeletal dysplasias. The scapula, if it's normal or hypoplastic. And I mentioned the foot length. The femur length to foot length ratio is approximately 1, and that is conserved through the second and third trimesters. If the ratio is over 0.9, it's usually associated with a constitutionally small or symmetrical IUGR fetus. If it's less than 0.9, that's strongly suggestive of a skeletal dysplasia. And here we see a femur length of 25 millimeters and the same in a foot length. Further evaluation, we want to look at fetal movement, the amniotic fluid volume, and whether there are any associated anomalies, especially cardiac, gastrointestinal, and renal. 3D sonography can be helpful. I'll show you some examples. And then amniocentesis can be helpful. And as I mentioned, it's changing literally every day with more mutations identified that we can screen for using amniotic fluid. And sadly, I have to leave the discussion of pulmonary hypoplasia to one slide. It is the most important prognostic factor in these pregnancies. And ultrasound is fairly accurate. Most studies have shown 85 to 95% accuracy with the diagnosis of lethal skeletal dysplasias. So we're not 100%, and I think that's also an important point. Sometimes the chest can look fairly small, but if we say that there is 100% lethality, we need to be very confident of that. And that's why I would urge caution in evaluating these pregnancies. Some have suggested that the thoracic circumference to abdominal circumference ratio is important, and I think that's actually a very good sign of lethality. Newer predictors, there's always something new coming out, and that's why this does deserve its own lecture. The femur length to AC ratio, surprisingly, not something you would tend to think of, but it can also be associated with lethality. Okay, so the last part of this lecture is where I convince you that we can diagnose the vast majority of them. So I looked at articles that had at least 100 cases of skeletal dysplasias, because you see a lot of case reports or small series, and that's always difficult to kind of wade through and understand what the relative presence, the prevalence of different diagnoses. But I looked at very large cases, and they're published studies, and they're listed here. And if you just look at the top 7 specific diagnoses, those make up over 70% of the in utero skeletal dysplasias. And it's very important to separate the in utero diagnoses from the pediatric, because obviously many of the lethal skeletal dysplasias will die very quickly after birth. So there are simply 7 that make up almost 3/4 of those that we would see prenatally. And they are listed here. And the most common is osteogenesis imperfecta, thanatophoric dysplasia. Those make up the vast majority. A lot of people think thanatophoric is the most common. I think they're pretty much tied for being the most common. Heterozygous achondroplasia is the most common non-lethal type of skeletal dysplasia. And then in lower percentages, we have achondrogenesis, short rib dysplasia, also known as short rib polydactyly, campomelic or camptomelic. You'll see both written, but campomelic dysplasia, and chondrodysplasia punctata. Those are the most common diagnoses that I was able to identify. So now I'd like to go through the distinguishing features of these, and that should help us in our diagnosis. So I will acknowledge this is a little bit artificial because there are subgroups of all of these, but as far as just the diagnosis, I tried to simplify it as best I could. So looking at the diagnosis of osteogenesis imperfecta, the key distinguishing feature is going to be skeletal demineralization, especially of the skull. So what we're going to see with that is we'll see may not be just that the skull is hypomineralized, but we're going to see the brain, especially the more the part of the brain that's closest to the transducer, we're going to see it very well. And as you know, those of you who do obstetrical ultrasound, as you get later in the second and into the third trimester, there's going to be a lot of shadowing of the more anterior part of the brain here that's closer to the transducer. But as you can see in all of these examples, we're seeing both halves of the brain very, very clearly. And that should tip us off that we're only seeing it clearly because there is hypomineralization of the skull. Sometimes if you push the transducer fairly strongly, we can see, as Dr. Lilly showed us, collapsing veins. We can see the head collapse a little bit and kind of bow in a little bit with some pressure from the transducer. And that can actually be helpful for us as we're trying to determine the diagnosis. We can also see beaded ribs, and here are some 3D examples showing irregularities of the ribs. You can see the beading on them, which is probably due to having had prior fractures. Sometimes you can see the fractures themselves, and here are examples of ribs that are fractured. Here we see other fractures. You can see this really angulated femur, and this one here, clearly they only become angulated like that if they had been fractured. So these are the things we should look for when we're looking for osteogenesis imperfecta. Thanatophoric dysplasia is the other very common skeletal dysplasia. And so what we'll see is severe rhizomelia. And we think back, it's going to be the more proximal bones, so the femurs and the humeri that are preferentially short in these, and they'll have a prominent forehead. So there are two types, and not to get into all the subtypes of these because that can be a lot for one short lecture, but type 1 is the more common, and you'll see bowed, and this is a type 1 here, and this is type 2 example here, and we'll see these bowed, what are termed telephone receiver, although I don't think anyone tends to have telephones like this anymore, except I do. But these bowed femurs that look like a telephone receiver, and they have a normal appearing skull. Type 2 has very short but straight long bones, and they'll have a clover leaf skull. So it looks a little bit like the leaf of a clover. And again, we talked about the size of the chest and how the ribs should go 70 to 80% around the chest. And you can see these ribs are very, very short. If you look at this coronal image, you can see that the abdomen is quite protuberant with this very small chest. I mentioned prominent forehead. You see a little bit of the prominent forehead, and then look at this chest here. And you remember from the heart talk we just talked about, this heart, if you look at it, is lying very flat in the chest, and you have the spine here. This is anterior, and that is a cardiac axis of about 90 degrees, not the normal 45, and the heart is taking up a fair amount of the chest. So those are the findings we see with thanatophoric dysplasia. Now, heterozygous achondroplasia is the third most common, and this is the most common non-lethal skeletal dysplasia. Again, rhizomelic shortening and mild limb bowing are very common with heterozygous achondroplasia, and rhizomelic, again, the upper arm bone, quite short. You'll have macrocephaly. You see this large head with mid-face hypoplasia. You'll see it really come in and be quite small in the mid-face. And here we have bowing of this femur. And then we also can see a trident hand. So you see these three different examples of kind of this Spock hand, like Star Trek you sometimes see. And you can see all these abnormalities of the hand. Moving on to achondrogenesis. These typically have severe micromelia, so the entire limbs are very short. But the key finding with achondrogenesis is the amount of calcification of the spine. So what you'll see, you can see the spine here, but it's very hypocalcified. It's not very white. You can hardly see the bones at all. In fact, in this image, you see the ribs, but you hardly see the spine. And that is the key finding with achondrogenesis type 2. And sometimes the skull can be affected also, but it's especially the spine that we need to be looking for. And again, here you see a severe micromelia with the lower extremity. You can't even make out the femur or the radius, and the tibia and fibula. They're just so incredibly short. You'll see short ribs with or without multiple fractures and macrocranium. But this is a really important image because you can see this very protuberant abdomen and a very tiny chest here. And again, you see some fractures of the vertebra. Of the ribs, and a very hypoechoic spine that is very difficult to see. Again, it's not just osteogenesis imperfecta that causes hypomineralization of the skull. And when you look here, you can see actually this more anterior part of the skull of the brain fairly readily. Short rib dysplasia, we used to say short rib polydactyly, severe micromelia, short ribs, and they frequently have polydactyly. So a very small chest here, the heart kind of lying flat within the chest, and then we have postaxial polydactyly here. You can see it a little bit on the 3D image also. Campomelic dysplasia. Looks like a few pictures aren't working right now. You see bowing of the long bones, especially the lower extremities. Absent fibula is very common. Club foot. Hypoplastic scapula. You can see this little scapula, but it's very tiny. And there are nomograms that you can look for these sizes. Macrocephaly with a small face, and actually this is one where you'll see sex reversal for males or ambiguous genitalia. So if you know what the sex is, that can be very helpful if it's male. And the last of our 7 diagnoses that we can readily diagnose antenatally is chondrodysplasia punctata. Pretty uncommon, but what you see is these calcified epiphyseal plates and stippling that you can see here. This is a postnatal x-ray, but this is something that's very rare, but that should tip you off to chondrodysplasia punctata. So when we're looking, just to review, for skeletal dysplasias, we want to measure and evaluate the characteristics of all the long bones. Look at the hands for trident, abnormal hand shape, or polydactyly. Feet, whether they're clubbed or not. The face and the profile. The skull size, shape, mineralization, and spine mineralization. Looking at the ribs for the size of them, how much of the chest they cover, and whether there are fractures present. And then the scapula, fibula, chest size, with the determination of lethality being the most important thing we can do antenatally. So in conclusion, a standardized approach is essential for evaluating fetuses thought to be at risk for skeletal dysplasia. And I want to stress that we can diagnose many, but some are not even diagnosed postnatally. So we can't be too hard on ourselves there. But the most important thing we should be able to try to do is to predict the risk for lung hypoplasia. Okay, thank you very much.